Good evening, doctors. Regards from Bayer Oncology. Thank you for joining today's discussion on prostate cancer. And today we have Dr. Shashanka Shekhar Das, sir. Sir is a senior consultant medical oncologist from NCRA, Kolkata. Sir, over to you, sir.
So, thank Sandeep for the introduction. And coming into the topic of today's discussion, so we know that there is every day there is a progression in the treatment of all the malignancy, including the prostate cancer, and currently the prostate cancer treatment has changed. A lot of new molecule has been came into the picture since the last 5 years, with the apalutamide, dialutamide coming into the pictures, and the role of triplet therapy, that is combining the chemotherapy along with the androgen receptor inhibitor, have proven its role in the management of prostate cancer. So here, along the recent development of the dialutamide, that is the aeronaut study, which have shown a significant benefit in the with dialutamide in patient with metastatic HSPC with dialutamide alone, because we know that all patients who are coming with the prostate cancer are not suitable for the chemotherapy, so there is always a restriction in our as a clinician while using dialutamide, because at that time the dialutamide was being approved as a along with the chemotherapy as per the RSN data. But now with the aeronaut study coming into the picture and it's being approved, we have a lot of scope of using the molecule dialutamide alone for our patient. And without going into the further discussion, I would call upon Dr. N. Thejeshwar for the discussion on reaching the new heights in metastatic HSPC care. So the stage is yours, Doctor. Thank you.
Thank you, sir. So I'm sharing my screen. So is my screen visible?
Yes, sir. It is visible and you're audible, sir. Please go ahead, sir.
So good evening, everyone. Thank you, Bayer, for giving me this opportunity. So I'm going to discuss about reaching new heights in metastatic hormone-sensitive prostate cancer care. So these are the disclosures. So first, before treating an prostate cancer, we have to understand the natural history of the prostate cancer. So if you treat an localized or locally advanced prostate cancer, then we follow up those patients. Then we are having three possibilities. One is they can develop an metastatic hormone-sensitive prostate cancer, or non-metastatic castration-resistant prostate cancer, and ultimately metastatic castration-resistant prostate cancer. Why this is important? Because when you identify the patients in a castration-resistant phase and treating them at that phase is associated with poorer outcomes, inferior survival. So that is a very important point which we have to identify in the entire natural history of an prostate cancer. So how we can improve outcomes in these patients then? So whether the most important thing is, one is identifying the patients where the disease is highly sensitive to the novel therapies and the treatments which we are having, and then acting at that point of time, especially that is metastatic hormone sensitive prostate cancer is very important, and this is going to result in significant improvement in overall survival, progression free survival, and it also delays progression to castration resistant phase. So this is very important. So with that background, if you see how we treat a patient with hormone sensitive prostate cancer. So in the era of docetaxel, that is, this trial is a Stampede trial, which was done in between 2005 to 2014. So if you see the control arm, that is an androgen deprivation therapy. So in this study, which was done in 2000, between 2005 to 2014, and in the control arm, if you see, that is with an androgen deprivation therapy. So the failure-free survival was very less. That is only 11 months. And the overall survival with an androgen deprivation therapy is 42 months. That is, it is, so now we can see that this disease, even hormone-sensitive prostate cancer with androgen deprivation therapy, we are not achieving what we want. We are not achieving a long-term survival. So there is definitely there is an unmet need, and definitely there is an area for us to improve the outcomes. So how we can do much better in this subgroup of metastatic hormone-sensitive prostate cancer? So one thing is with the addition of radiotherapy to the androgen deprivation therapy, whether it is going to improve the outcomes or not. So again, this was studied in two important randomized trials, and the outcome of these trials is overall there is no difference in an overall survival if you add prostate radiotherapy to the androgen deprivation therapy. But in a secondary analysis, it was shown that if a patient is having an metastatic bone disease burden, that is less than 4 bone metastasis. So in that subgroup, it was shown that addition of prostate radiotherapy is associated with improvement in failure-free survival and also overall survival. Mind that it is an secondary analysis. However, it improves survival in a patients with low volume bone disease. One is addition of radiotherapy to improve the failure-free survival and overall survival, maybe in low bone disease patients, and it is a secondary analysis. Coming to the systemic therapy in this setting. So here we can see from 2013, in the past decade, there are plethora of randomized control trials were done in this setting. So this includes, here we can see 10 randomized control trials. This starts from docetaxel and to darolutamide. So it includes docetaxel, abiraterone, and also second generation androgen receptor blockers. So with all these things, so all these trials have shown that improvement in overall survival if you add a systemic therapy in the form of an chemotherapy or an hormonal therapy, it is going to be associated with an improvement in overall survival. However, in most of these trials, the control arm is androgen deprivation therapy. Few trials included control arm of in few trials it was docetaxel. So yes, among them, the important one is PEACE trial, where docetaxel was the standard of care, and Arasens also is used in triplet therapy. And Enzamet used non-steroidal androgen anti-androgen therapy, that first generation ones in the control arm, that is bicalutamide, flutamide, etc. So in the next few slides, I will discuss about the important points in these trials. So here with these trials, we can see that all the patients, in all the patients with the addition of a systemic therapy, there is going to be an improvement in survival. Next, we see whether we have to give systemic therapy to all the patients or not. Number one, especially docetaxel to all the patients or not. Are there any subgroup of patients that are going to derive a real benefit with the systemic therapy? So come to the most important thing, that is the charted trial, which has used docetaxel versus ADT alone. So it was shown that we all know about this data. It has shown that high volume disease, that is presence of an visceral metastasis and or more than four or more than 4 bone mets. Among them, one has to be non-vertebral mets. So in this high volume disease, it is the addition of docetaxel has shown benefit. Whereas in a low volume disease, addition of docetaxel, there is no added benefit. That means addition of docetaxel showed benefits in a high volume disease, high volume metastatic hormone sensitive prostate cancer. That was given by a charted trial. And if you see the absolute benefit with an HR value of hazards ratio of 0.63 and the delta of 17 months, that is significant benefit. Whereas if you see the delta in low volume disease, there is no difference. So one thing is docetaxel addition has shown benefit mainly in high volume disease patients. And coming to the another most important agent, that is abiraterone. So in this latitude trial mainly included patients who are having a high risk disease, that is defined by patients who are having a Gleason score of more than or equal to 8, and patients who are having a visceral metastasis or bone metastasis of 3 or more. So in this high risk subgroup of patients, addition of abiraterone has again showed an improvement in overall survival. So especially in an high risk, so this abiraterone here included mainly in high risk patients, and it has shown improvement in overall survival. And this study also has met all the secondary endpoints, that is pain progression, skeletal related events, chemotherapy initiation, subsequent prostate cancer therapy, and prostate specific antigen progression also. All are delayed with abiraterone therapy when compared to androgen deprivation therapy. So again, abiraterone has shown benefit in high risk patients. However, there are going to be and one important thing in this trial is abiraterone was along with abiraterone, prednisolone was given at 5 mg once daily. Even after giving an 5 mg once daily with abiraterone, there are certain toxicities are higher. One is hypertension. Here we can see 22% of grade 3 or more hypertension, grade 3 or more hypertension, and along with that, hypokalemia is also seen in 11% of the patients. So when compared to placebo, there is a significant higher incidence of clinically significant higher incidence of hypertension and hypokalemia with addition of abiraterone. And we also know that giving prednisolone for a longer period of time is associated with certain prednisolone specific toxicities. So that is going to be a challenge with prednisolone, with abiraterone. So coming to the next, another important second generation anti-androgen therapies, it is apalutamide. So apalutamide, again, it was compared with androgen deprivation therapy. So it has shown in a Titan trial, it has shown that improvement in progression-free survival and overall survival also, with an hazards of around 0.65, then significant improvement. And the progression-free survival benefit is seen in low volume and also high volume patients also. Whereas the overall survival data is yet unknown. So whether it is going to be beneficial or not in case of based on the volume of the disease is yet to be, we have to wait for a long-term results. And another one is enzalutamide trial, that is ENZAMET trial. Here also, we know that there is going to be improvement in survival. However, if you see a subgroup analysis versus of low volume versus high volume disease, the benefit of enzalutamide mainly seen in a subgroup of patients who are having a low volume disease, whereas it is not statistically significant in patients who are having a high volume disease. This one we have to keep in mind. Here, the control arm included non-steroidal anti-androgen agents, that is bicalutamide and flutamide. So enzalutamide, the benefit is not statistically significant in high-risk patients. Whereas docetaxel, it is not, based on the charted trial, it is not significant benefit in low volume disease patients. So how we can address these challenges? Whether addition of an other agents like other modalities of treatment is going to further improve the outcomes in this difficult to treat population, we'll see in the further slides. So one is PEACE-1 trial. So PEACE-1 trial, it is an factorial design, 2x2 factorial design. The patients with de novo metastatic hormone-sensitive prostate cancer included both high volume and low volume disease with good performance status. So there are 4 arms, that is standard of care. The standard of care includes ADT plus docetaxel or ADT alone. Then one arm is a radiotherapy arm, that is standard of care with radiotherapy arm. And another one is an abiraterone arm, where standard of care therapy with abiraterone, and the fourth one is abiraterone plus radiotherapy. So this is the study design. This is a factorial design. So if you see the subset of patients who received ADT plus docetaxel plus plus or minus abiraterone. So if you see that subgroup, that is triplet therapy with the docetaxel was given to all the patients and plus or minus abiraterone. This has shown, if you see, based on the high volume and the low volume disease, and the benefit is mainly seen in a high volume disease rather than a low volume disease. So again, based on this PEACE-1 trial, the addition of abiraterone to docetaxel and ADT in a low volume disease is questionable. Coming to the ARASEN study, which is a clean study design in a metastatic hormone-sensitive prostate cancers of more than 1,000 patients with good performance status eligible for docetaxel. These patients were randomized in an 1:1 fashion to darolutamide, which is the darolutamide versus placebo, and all patients received docetaxel with androgen deprivation therapy. Primary endpoint, again strong endpoint, that is overall survival, and the secondary endpoints includes pain progression, which were seen in an as seen in latitude trial, time to progression, skeletal related events, and first symptomatic skeletal related events. And another one is castration-resistant prostate cancer, worsening of physical symptoms. And also another important endpoint is also that is progression in PSA values also, that is also there. So, and another important thing is there is no much difference in the control arm also. Nearly 87% of the patients received in the control arm versus there is no much difference in the standard of care therapy. Nearly 87% of the patients received docetaxel, which is almost similar to an real world setting. So if you see the primary endpoint, that is the overall survival, there is a significant benefit with a delta of 13% with addition of darolutamide to the docetaxel and androgen deprivation therapy with an hazard ratio of 0.68, which was very meaningful. And subset, so as we see previously, high risk the benefit is seen irrespective of whatever subgroup it may be. It is an high risk or low risk. Benefit is maintained, that survival benefit is seen. And coming to the other secondary endpoints, that is time to castration-resistant prostate cancer, which is a very important endpoint, where we know that castration-resistant prostate cancer is associated with, once a patient develops CRPC, they are having a very poor survival. So time to CRPC is again significantly better with the addition of darolutamide, and time to second line therapy, and also pain progression and secondary skeletal events. So all these secondary endpoints were significantly better with darolutamide when compared to standard of care. And coming to the most important endpoint, that is undetectable PSA. So overall, nearly with this therapy, overall population, if you see, nearly 2/3 of the patients will achieve an undetectable PSA levels. And these undetectable PSA levels, especially at 36 weeks, is associated with improvement in overall survival when compared to patients who are having a detectable PSA levels at 36 weeks. This was also found. It means undetectable PSA levels, the dynamics of PSA are also predicting the overall survival. Coming to the high risk group, nearly again 60% of the patients achieves undetectable PSAs, and we know that it is associated with improved overall survival. Here, if a patient is having an high risk, high volume disease, and he is having an PSA values undetectable at 36 weeks, then it is associated with very good survival, very good overall survival when compared to the patients who are not who are having undetectable levels. Okay, so then other important thing is in a low volume disease. In a low volume disease also the benefit is maintained. So the benefit of this undetectable PSA is maintained in both low volume disease and also in a high volume disease. Yeah, sorry. So the benefit of this PSA, the PSA dynamics is maintained in both low volume and also high volume disease. So even the patients who are having a low volume disease and they are having an undetectable PSA levels are having a very good survival. So the most important thing from this entire discussion is, first we have to see whether the patient is fit for, whether the patient, we have to see the life expectancy, and also whether the patient is able, what are his comorbidities, whether it is controlled or not, and he is able to tolerate triplet therapy or docetaxel or not. So that is the first important thing which we have to see. And then other important disease characters which we have to see is what is the volume and what is the risk. So, and also why? Because if they are having, patients are having a high volume disease and a high risk disease, there are higher likelihood of having hormone insensitive clones. Okay. So, and another important thing is, especially in our setting, most of the patients cannot able to receive second line and third line therapies because of various reasons. There will be a lot of attrition. So if the patient is fit enough for a triplet therapy, it is always better to go with a triplet therapy and so triplet therapy. So we have to discuss each and doublet therapies, triplet therapies, and with the patients, and we have to decide the therapy which is going to be better for him based on his comorbidities and his disease status. So we all know that currently, based on the available data, Arason's data has shown that improvement in survivals in each and every subset, even high risk and high risk disease and low risk disease, and also high volume and low volume disease, and it is associated with lesser CNS toxicities, like because of its lesser CNS penetration. So that makes this drug as an attractive option in this subset of patients. Thank you.
Thank you, sir. Shashank, sir, are you there, sir?
Yes.
Sir.
Sir.
So,
Over to you, sir.
yes. So thanks, Dr. Tejoshwar, for the wonderful session. And I would like to call Dr. Ini Reddy for the next session on advancing metastatic HSPC treatment horizon with regarding the ARANOT evidence of dialutamide without chemotherapy, which is a very recent update. And ma'am, the stage is yours, and please start your session.
Thank you, sir. I hope I'm visible and
You're
audible.
audible, ma'am. Yeah, you're audible, ma'am. With your permission, can I share your slides?
Yes, please, please share my slides.
1 second, ma'am. Yeah.
My internet connection is not so stable. If you lose me, just let me know. Or if you're not able to hear me, please let me know. Okay.
Sure. Thank you. Ma'am, I won't be able to speak, but you just tell me when to change the slide. That's all.
Yeah,
Because
I'll let you know. I'll let you know when to change the slide. Okay, so the slides are visible, and let's start with today's discussion. So good evening, everyone. Today I will be discussing on the evolving treatment landscape of metastatic hormone-sensitive prostate cancer, with particular focus on darolutamide used without chemotherapy. And this is based on the ARANOT trial evidence. And over the next 30 minutes, we will look into how the standard of care in hormone-sensitive prostate cancer has evolved, and what are the unmet clinical needs that still exist in this area, and the rationale behind the ARANOT study design and the key results of the ARANOT study, and how is it applicable in our clinical practice. Today's discussion, at the end of the day, all discussions, we should see how they are applicable in our clinical practice. So this topic is highly relevant to all of us, because many of our patients with metastatic prostate cancer, they're elderly, they have comorbidities, or they might not be suitable candidates for chemotherapy, or some people might be just unwilling to receive chemotherapy. So let's see how we can use darolutamide without chemotherapy. What is the evidence for this, etc. Next slide, please. And these are my disclosures. The slides have been provided by Bayer for the meeting, and they are for scientific purposes only. Okay, this slide depicts evolution of standard of care in metastatic hormone-sensitive prostate cancer. We know that the treatment landscape landscape of the metastatic hormone-sensitive prostate cancer has changed dramatically over the last decade. And as Dr. Tejeshwar rightly pointed out, historically, androgen deprivation therapy alone was the standard. But now there are multiple landmark trials which have demonstrated survival benefits with treatment intensification. I think Dr. Tejeshwar discussed everything in detail. Briefly looking at these things, the combination of ADT with docetaxel was looked into in Chartered and Arm C of Stampede trial. Then the combination of ADT with abiraterone was looked into in Latitude and Stampede Arm G. Then there came the apalutamide plus ADT, which was tried in the Titan trial. And the combination of enzalutamide plus ADT was looked into in the ARCHES and the Enzamet trial. And more recently, this triplet therapy with darolutamide along with ADT and along with docetaxel chemotherapy, it has demonstrated significant overall survival benefit, as was discussed by Dr. Tejeshwar in the Arisons trial. However, despite all these advances, as I already told, many of the patients will still progress to metastatic castration-resistant disease within approximately 3 years. Therefore, there is an unmet need for those treatments that are highly effective, treatments that are well tolerated, and treatments that are feasible for a broader patient population. So let's look into what we can change in our practice. Next slide, please. Next slide, please. As we all know, darolutamide has already demonstrated strong efficacy in combination with docetaxel in the Arisons trial. However, chemotherapy is not appropriate for each and every patient. As we all know, there could be elderly, frail patients or patients having significant comorbidities who might not be willing for chemotherapy. And also, in elderly patients who are already receiving treatment for comorbidities, we are really concerned about the drug-drug interactions if we are placing them on any oral medications. So darolutamide has pharmacological advantages in this way. There is minimal blood-brain barrier penetration for darolutamide, and there is lower risk of CNS toxicity, and is also a very low potential for drug-drug interaction. Next slide, please. So this became the background for the Arno trial. The Arno trial was designed to evaluate darolutamide plus ADT without chemotherapy. So next slide, please. Arno is a phase 3 randomized double-blind placebo-controlled trial. In this, a total of 665 patients with metastatic hormone-sensitive prostate cancer were enrolled, and patients were randomized in a 2:1 ratio to receive darolutamide plus ADT or placebo along with ADT. And the key eligibility criteria were histologically confirmed prostate adenocarcinoma, ECOG performance status of 0 to 2, metastatic disease which was confirmed on imaging. The primary endpoint here was a radiologic progression-free survival. And the secondary endpoints included overall survival, time to castration-resistant disease, time to PSA progression, pain progression, safety, and of course, quality of life. And the median follow-up in this trial was approximately 25 months. Next slide, please. Coming to the patient characteristics, as we can see that the baseline characteristics were very well balanced between the two treatment arms. Importantly, the study included a broad spectrum of patients, patients with both high and low volume disease, patients with and without prior local therapies, and they've also included patients with visceral metastasis. So this diversity is very important for us because it improves the applicability of the results to the real world clinical practice. Next slide, please. This Aeronaut was an international trial with patients recruited across multiple regions, including Asia, Europe, and the rest of the world also. And a substantial proportion of the patients, they were from the non-Western populations, which enhances the generalizability of the findings, and it increases the relevance to our patient population. Next slide, please. Coming to the primary endpoint, as I told, the primary endpoint of this trial was a radiologic progression-free survival. Here we can see that darolutamide along with ADT, it significantly reduced the risk of radiographic progression or death by 46% when compared to ADT alone. The hazard ratio here was 0.54, which was highly statistically significant. The median radiologic progression-free survival was not reached in the darolutamide arm, and it was approximately 25 months in the placebo arm. You can also see clearly that there is early and sustained separation of the Kaplan-Meier curves, which indicates a robust treatment effect. And this magnitude of benefit is also clinically meaningful, and it is comparable to other androgen receptor pathway inhibitors used in this context. Next slide, please. The important strength of this study is the consistency of benefit across the subgroups. We can see here that the improvement in the radiologic progression-free survival, it was seen regardless of the disease volume, may it be low volume, high volume. It was seen regardless of the PSA levels, regardless of prior local therapy, whether they received any form of local therapy or no. And it, as I already said, the trial included patients with a EFOG performance status of 0 to 2. And there was also benefit in all groups of patients, irrespective of the presence or absence of visceral metastasis. And we can see clearly that there was no subgroup where darolutamide performed worse than a placebo. And this reinforces the reliability of the treatment effect. Next slide, please. Here we can see that darolutamide, it also demonstrated benefits across multiple secondary endpoints. The secondary endpoints are delay in the time to castration-resistant disease. There is delay in the PSA progression. There is reduced need for subsequent anti-cancer therapy. And there is improvement in the symptom-related outcomes. And but at the time of this analysis, the overall survival data were immature. Also, in the placebo arm, the patients in the placebo arm, they were allowed to cross over to darolutamide after the primary analysis. This might influence the future survival interpretation too. Next slide, please. Here we can see that one of the clinically meaningful findings here was the delay in progression to castration-resistant prostate cancer. Additionally, darolutamide also significantly delayed the pain progression with a hazard ratio of 0.72. Pain control, as we all know, is extremely important for the patient's quality of life and daily function. This meaningful delay in pain progression has not been consistently demonstrated with all the androgen receptor inhibitors, and this observation is particularly specific for darolutamide. Next slide, please. Darolutamide also achieved deep and durable PSA responses. Here, approximately 63% of the patients achieved the PSA levels below 0.2 nanograms per ml. And there was a 69% improvement in the time to PSA progression when compared with ADT alone. Deep PSA responses, they often correlate with improved long-term outcomes, and patient also feels reassured regarding the treatment efficacy. Next slide, please. These benefits like the deep PSA responses were also seen in both high volume and low volume disease patients, as we can see here. Next slide, please. They required subsequent life prolonging therapy. This suggests that the disease control was more durable and it will translate to improved quality of life and lower treatment burden over time. Next slide, please. We now come into the details about the safety of the drug. Of course, safety is a critical consideration, especially when we are treating elderly patients, those with comorbidities. The overall incidence of treatment emergent adverse effects, it was similar between both the groups. And interestingly, discontinuation due to adverse events were actually lower in the darolutamide arm. The safety profile was consistent with the previous darolutamide trials. And there is good tolerability of the drug because of its unique pharmacological characteristics. Like, as I already discussed, there is vein penetration and there is lower potential for drug-drug interaction with darolutamide. Next slide, please. The most commonly reported adverse events, they are all generally mild and they were similar between the treatment arms. And the most commonly reported adverse events were the fatigue, hypertension, rash, and liver enzyme elevations. And there were no new safety signals in this trial. Next slide, please. Adverse events which are typically associated with the androgen receptor pathway inhibitors, such as the falls, fractures, cognitive effects, they're all similar between the two groups. This further supports that the drug is quite tolerable and when compared to other androgen receptor inhibitors in this class. Next slide, please. Coming to the quality of life, we all know that oncology, especially in the metastatic setting, we all look into the quality of life of the patient. So darolutamide delayed the deterioration in the overall quality of life, as was measured by the FACT-P score by approximately 5 months when compared with the placebo. And darolutamide is a full delays in pain progression and to demonstrate a meaningful improvement in the overall well-being of the patient. Next slide, please. We can see here that improvements were seen in terms of social well-being, functional well-being, improvements in urinary symptoms, and further analysis also demonstrated benefits across other multiple domains, including the physical and the emotional well-being of the patient. So we can say that the darolutamide has multiple benefits. Only it extends Sandeep, can you go to slide, please? Yeah. So with this, we come to the conclusion of today's note study. To summarize, so sorry that I got lost. Am I audible now?
You're audible, ma'am. Please go ahead.
Okay, so with this, we conclude the conclusion of today's talk on the aeronaut study. To summarize, here the darolutamide plus ADT, it has resistant disease, and it also delayed the pain progression. Darolutamide also demonstrated a favorable safety profile and an improved quality of life. So, in short, we can say that darolutamide plus ADT without chemotherapy, it represents an important new treatment option for patients with metastatic hormone-sensitive prostate cancer. And this chemotherapy-free approach is especially useful for elderly patients, patients with comorbidities, and patients suitable for patients who are not willing for chemotherapy. This comes to the conclusion of this talk. Thank you, everyone.
Thanks, Dr. Reddy, for the illustrative discussion on the topic of the run-out study. And so the next speaker will be me regarding a real-world case study of metastatic HSPC case. So not share the slide. So,
Sir, with your permission, you want me to share the slides? Or
yes, if that can be
I will be
possible.
just a minute.
Share.
I'm sharing.
Oh, let me share from my end. Hi, Sandeep. You stop sharing. I'm sharing from my end. Okay.
Okay, sir. Yeah, please go ahead, sir. Yeah, thank you.
Am I visible?
No, sir. The slide is not visible. You're audible but not visible, sir.
Okay. Share from your end only. It's causing problem.
Okay, sir. Give me a minute, sir. Yeah, it is already open. Yeah, I'm sure.
বেরিয়ে যাও, চাবিটা দিয়ে দাও। সেটা অন থাকো। সুইচটা টিপলে অফ হয়ে যাবে। আর চাবিটা নিয়ে জাস্ট লক করে চলে যাবে।
Sir, please go ahead.
Yes. Thanks, Sandeep. So this is a case of a real-world case of metastatic HSPC. The patient, as per next slide. So he was a 70-year-old gentleman, and he was unfortunately diagnosed with both a metastatic HSPC and a small cell lung cancer, localized stage, and he was initially treated for the localized stage small cell lung cancer with the cisplatin etoposide and along with the RT. And then he was started on treatment with apalutamide as a treatment for the metastatic HSPC. He underwent surgical castration, and the baseline serum PSA was 127 in the July 2023 when it was started. He was initially started on the treatment outside, and then when he came to me, next slide. So he was initially metastatic hormone-sensitive prostate cancer with a high-volume disease of bone mets, both above the level of the pelvis, and the Gleason score was group 4. He was hypertensive, hypothyroid with the ECOG PS1. Next slide. So when he came to me, he was having toxicity with the apalutamide. So apalutamide was stopped and the dialutamide was started. But I think the slide need to be changed because the patient didn't receive the triplet therapy with those dialutamide, but only a single agent dialutamide because the patient, we haven't started with again the chemotherapy because patient have already received a chemotherapy few months back because of the small cell lung cancer, and so we haven't started him on chemotherapy. We have started only on dialutamide and injection denosumab. Next slide. And in the PSMA PET-CT in the June 2025, the prostate gland was bulky of 4.1 into 4 centimeter, and no focal FDG uptake or enhancing lesion was seen. Next slide. And he is currently responding well to treatment and monitored with serial PSL level. And the last PSL level, which was done on 16th of June 2025, was 0.02. Next slide. Next slide. He had occasional grade 2 diarrhea and mild alternation in taste sensation. Apart from that, the treatment is being tolerated well. Next slide. And he is continuing dialutamide of 300 milligram BID dose. Next slide. So thank you. And with that, I conclude my presentation. And if there is any question, I'll be happy to take. So to the organizer, if there is no further question.
Thank you, sir. Thank you for your time. Sorry, sir. Sorry for the some
Sandeep.
technical. Yes. Sir, am I audible?
Yes, yes.
So thank you, sir. Some technical issues were happened, but I hope we could able to cover all the topics, sir. So let me
Yes,
check the
yes.
chat box, sir. Give me a minute, sir. Please allow me for a chat box to check if there is any questions.
Okay.
So, sir, I don't think there is any questions from the chat box. So I think with this we can conclude the session. Thank you, Dr. Shashanka, sir, for your taking your time and presenting the case. And I sincerely
Thank
thanks to Dr. Tejeshwar, sir, presenting the data on RSS, which is triplet. And Dr. Shaini, ma'am, thank you so much, ma'am, for presenting the data on RNote. So I think with this we can conclude the session, ma'am. And thank you, sir.
Okay.
So
Thank you,
good night.
Sandeep. Good
Yeah.
night.
Yeah,
Technical
thank you,
team.
Sanjay.
Yeah, thank you, ma'am. Thank you so
Right.
much. Tejeshwar, sir, thank you so much, sir. Thank you.